in
How do you administer the glucose?
so the glucose we have to put it in 300 ml of water, mix it, and the patient has to be encouraged to intake it within 5 minutes, because most of the time vomiting occurs. So we have to counsel the patient and advise them to take it within 5 minutes. And if vomiting occurs, then we'll have to not.
So any pediatric resident there? So so what is the dose of glucose in when you would you treat in the pediatric population?
Sir, it is 1.75 gram per kg.
Very good, please. So this is the protocol, and has been told by the resident concerned. So the patient has to be fasting, and that means the patient should not consume any calories for 8 hours preceding this test, and has to be consumed over 5 minutes. So this patient had some evidence of dysglycemia during her pregnancy. And we are also aware that diabetes is a predominantly asymptomatic disease. So concept of screening is very, very important in this. So Major Satish, can you help us? What are the criteria for screening of diabetes?
The patient who is having the history of gestational diabetes, a patient who are having a high risk factor like cardiovascular risk, disease, morbid obesity, then hypertension, age more than 35 years, this all patient has to be screened.
Age more than
35, sir.
Please. So this is a guidance which is available from ADA when how do we screen the patient with for the diabetes. So it's a busy slide. What I am trying to highlight here is this. So basically, all the patients beyond 35 years of age, whether or not they have any kind of symptom, should be screened for diabetes. And what is important is with every passing year with ADA supplement, we are decreasing this age. Around 2 to 3 years back, we were discussing this age around 45 years, then it became 40, and now we have an age of 35 years. So having said that, other indications are like any overweight, obese individual, some kind of risk factors of family history. What is the inference of this is, when we apply this criteria in adult normal population, almost all of us would fit into the screening criteria beyond the 18 or 20 years of age into screening for diabetes. So that is the importance of screening. Another thing which I have highlighted here, all the people with gestational diabetes have to be screened every 1 to 3 years. You remember this patient had dysglycemia during the pregnancy. And in fact, these days we are talking about opportunity in gestational diabetes. Means the gestational diabetes is considered as an opportunity where we can intervene so that further development of diabetes and complication of diabetes can be prevented in such women. So, and this opportunity in this patient probably was missed because of the whatever reasons. Fault is at their end and at our end as well. So, do we have community medicine resident there? So, can you help us understand what epidemiology of diabetes with Indian perspective?
So, Southeast Asian population, basically, or Indian population, they are more prone to diabetes. There are certain reasons due to which they are more prone to diabetes.
Can you back up some numbers on diabetes?
So worldwide, we have prevalence of diabetes as 10.6 to 10 to 11% approximately, and as a for NFHS data, it is like in females it is 6.5, and in males it is 7.1%. And we are more prone to diabetes because we have
Indian data.
So it is as per NFHS data, sir. Yes, sir. 7.1 and 6.5 in females and 7.1 in males.
Please. So whenever we talking about epidemiology of diabetes, so this is the modern day epidemic which we are dealing with. We should refer to ICMR India data, which was published in 2023. This is a landmark paper which was done in about 30 cities, and 1,13,000 people participated in this study. And when we go through this data, we get very, very surprising number, not 7.5%, which is a very good data. The prevalence of diabetes in India is 11.4%. Prevalence of pre-diabetes 15.3%. If you add these two numbers, we are having about 25% in reproductive age group. That is very, very high numbers. And this study also told us that about prevalence of obesity is about 40% in Indian scenarios. And this paper also brought up the discussion that Indians have very, very intriguing characteristics, that every third family in India has a diabetic patient, and for every one patient which is diagnosed in India, one remain undiagnosed. So this is the tip of the iceberg, and probably we are scratching the surface only. Huge number remains underneath this iceberg which need to be diagnosed, and the screening is the answer for this. And this is the paper which I was referring to. All the residents across, irrespective of the specialty, should go through this paper. Was published in 2023, ICMR India study, our largest, best recognized data with respect to epidemiology of diabetes and metabolic diseases. And as he said, Asian Indian phenotype. So basically, what are the characteristics of Indian and Asian populations? That we tend to have a more adipose tissue content in subcutaneous and organs with the same body mass index. We have higher markers of inflammation. We have a lower adiponectin levels. It has been seen that India developed diabetes about a decade earlier compared to their Western counterpart. And once we develop a diabetes, we progress rapidly to the complications. And in fact, this weight and obesity thing is called as a normal weight obesity. Means Indian people, it has been seen with a normal BMI cutoff. For example, if a person is having a 22.5 body mass index, he may be having a higher body fat percentage in there. So, Robin, what is this Y-Y paradox?
Sir, this paradox, sir, it was seen in the early 2000s, sir. It was by a scientist, sir, where he observed that by two physicians, sir, Yasnik and Yudnik, sir, both were having similar BMI, sir. But the Indian physician, sir, he had more of body fat, body fat percentage.
So it is not decade back, but it is always seen. It was described a decade back. So what happened is Dr. Yasnik is from Pune. It is a very stalwart diabetic researcher. And this Y-Y paradox is very, very extensively quoted in the very high impact literature. So what is happening? Dr. Yasnik is here who's sitting. He also came to the FMC during Illuminati last year. So what happened is he took his counterpart, who's a Western, and his BMI, and both of them had a BMI of 22.3. Then what did he do? He did a body fat composition with a DEXA. And to the surprise, Dr. Yasnik was having a 2.5 times higher fat percentage compared to Dr. Yasnik. So this is called as Y-Y paradox. Any pediatric assistant? Please. So please study, you're dealing with a patient with a diabetes in your clinic and you have such a pedigree. So what does this tell you? Just the pattern of inheritance.
Sir, so both sexes are involved and there is carrier also. So, sir, this is a recessive form of.
So basically, multi-generational diabetes. I'm not getting into the complex of inheritance, but multi-generational diabetes, whenever you're dealing with, please think of maturity onset diabetes of young, which is called a MODY. We have different types of MODY, and what is a MODY? It is an autosomal dominant, which is associated with the beta cell dysfunctions, and various characteristics are there. An important thing to remember is the MODY2, which is due to the GCK deficiency, which has a mild hyperglycemia, which generally does not require treatment. And this entity is it's very important to differentiate this entity because treatment strategies different. At times, your patient may simply respond to your sulfonylureas.
Coming to the general examination, my patient was conscious, oriented. Her pulse was 70 per minute regular. Her BP was 106/74, right arm supine with no postural fall. Her respiratory rate was 14 per minute with SpO2 of 98% at room air. She had pallor, pedal edema. However, there was no icterus, cyanosis, clubbing, or lymphadenopathy. Her height was 152 centimeter with weight of 32 kgs. Her BMI was 15.1 kg per meter square. She was cachexic with loss of buccal and temporal pad of fat. Her skin was loose and wrinkled and dry. She had glossitis with grade 1 acanthosis nigricans. There was no koilonychia.
Acanthosis nigricans. So this is a patient, an image of the patient, which when she was presented to the hospital. What is acanthosis nigricans? And what does it signify?
Acanthosis nigricans is
Use a mic, please.
pigmented velvety skin, sir. It present in metabolic disorder and some malignancy, sir. And it is classified. There is a scale used for.
So it is a marker of insulin resistance, but can also be seen in certain malignancies. Are you aware of any other markers of insulin resistance which can be picked up on general examination?
There are, sir, cutaneous markers are there, sir. Diabeticum, xanthoma, and diabetic.
So we can have an ectocordon, which is called as skin tags. Acanthosis nigricans can be present. Patient can have a double chin, and etc. These are the features. Hirsutism, etc. This is a feature of insulin.
Central.
Yes, the surrogate markers of dyslipidemia can also be there, which can be said to be markers of insulin resistance. So any dermatology resident? So basically, whenever acanthosis nigricans is present, we can also classify it according to the grade. So where do we look for acanthosis nigricans? Generally in the neck, but it can also be present in the axillary region, even in the face and also over the knuckle areas. And we can also, because we are physicians and we have to, practice medicine according to the objectivity so that we can decide about the severity. So this classification can be used, and that means that simple nape of the hyperpigmentation limited to the nape of the neck only, and grade 4 means it is the severe hyperpigmentation where it can be seen from even from the front. So any pathology that's in here? So what will happen if we do the HP of the cancer diabetes?
Sir, there will be acanthosis. It means, sir, there will be hyperkeratosis, and there will be present of basal layer will be increased.
So hyperkeratosis and papillomatosis are the three features of the cancer cycle. And why does it happen? Because it is an anabolic or mutagenic kind of hormone. Okay. So this was present. Any dermatology resident here? Okay. So this was present in our patient. What is this?
Sir, this is diabetic, most likely diabetic dermopathy.
Very
Reddish to
good.
brown
Like
papules
the
on the shin.
which is also a surrogate marker of
Yes,
underlying. which
it's
is
one of the
associated with the
specific
microvascular
markers of diabetes.
complications, and it is basically seen as a papules on the bony surface, as this was present in our patient on the shin area, and it leaves a atrophic and depressed kind of scar. What is the clinical relevance? It is associated with the
Sir,
microvascular macrovascular.
Yes, 30% of the patients with diabetes can have diabetic dermopathy. It's one of the most common, and it is a specific marker for diabetes.
Very good. So we have another question for you. So this is from the same patient. It's a representative which has been taken from the text. What is this?
Sir, this looks like perforating dermatosis. Sir. It's also one of the non-specific markers of diabetes.
So this is the necrobiosis lipoidica diabetic coda seen in about 1%. It is important to understand here is, as compared to the other dermopathy, it is an autoimmune plus a microangiopathy, and it presents the papules and nodules, which leaves a red, brown, and yellowish flowers. And these are the various skin manifestations.
Necrobiosis lipoidica has a specific feature, sir. It has a central yellowish appearance with peripheral reddish appearance, and central appearance will be lightly shiny. So,
good. Say.
Coming to the systemic examination, in central nervous system, her higher mental functions were normal, her speech and cranial nerves were normal, motor system was essentially within normal limits. Her sensory system, she has impaired vibration sense till both the knees. In 10-gram monofilament, she scored 3 by 10. Her proprioception was intact, her pain and temperature was intact. Her cerebellar functions were normal, her fundoscopy revealed no retinopathy. Her other systemic examination were essentially within normal limits. Coming to the lab investigations,
Sir, we have anemia, diabetes, and urine for ketone is also positive, and RBS also indicates diabetes, sir.
So any electrolyte abnormality?
Sir, albumin globulin ratio is, and sodium is also reduced, sir. Yes.
And HbA1c?
HbA1c is high, sir, more than
What is
6.5.
Modius hypothesis? Anyone Modius hypothesis? So basically, Modius hypothesis is a hypothesis which was given, which makes an attempt to study what is the contribution of fasting and postprandial glucose in HbA1c. So when your HbA1c is very well controlled, means around 7%, the major contribution would be from the glucose, 2R glucose, postprandial glucose would be contributing more. But when your HbA1c is more than 10%, the contribution would be maximum from your fasting plasma glucose. And what is the clinical importance of this is that whenever there is a hyperglycemia which is uncontrolled, try to control the fasting first. That is the principle of clinical medicine. And why sodium, please? Good. So, Major Sudendra, why there is a sodium low in this patient?
Sir, because of high glucose, it will lose in the kidney, sir. It goes with the sodium loss.
Please, Akash, why there is a sodium low?
So the patient has a RBS of 722. So actually this is a false sodium report. We need to correct it for the hyperglycemia, sir.
So very good. So it is we have to correct, the correction of the sodium has to be done for the hyperglycemia, but the correction factor 1.6 of every 100 rise beyond 200. So if we correct the sodium in this patient, it would be very high. So it is very, very important we do, calculate the serum osmolality when we are dealing with hyperglycemic hyperosmolar state. So Akash, can you tell us if we have a patient of diabetic ketoacidosis versus hyperglycemic hyperosmolar state, which patient would have higher mortality?